So we have two topics to cover today in 1.5 hours, and we're going to float in from one to the next. One is research priorities that are coming out of the last 3 days. We have a scientific meeting preceding the family meeting, where we sat together as a scientific community and talked about things, and then we had, of course, a day yesterday where lots of members of the LAMA2 division can all discuss. And today, I think the idea is to come up with a little bit of a priority list of research priorities that, you don't have to order the hierarchy, but the ones that are most burning. And then we go a little bit into care considerations as well. So the way I would like to do that is to see, first take a vote from the affected families to see what are your research priorities, what have you taken out of the day yesterday and the days before that you think are the research priorities that the research community should be putting up front and center. And then I have in the next slide a list of research priorities that I kind of extracted from the last few days that we can then discuss with you and the researchers in the room to see how we approach them, what are the bottlenecks, what is realistic to expect, and what is happening in what order, hopefully, and where do we need to focus. That sound good? Do we have a floating microphone?
Yeah,
okay, good. So feel free to start. Anyone just throw out anything that you think is a priority, something that hasn't been mentioned enough, something that we should pay more attention to, something that you're particularly excited about, that you want to see move forward. And then we take it from there. Don't be shy. There's no stupid ideas here.
So I have a couple of patients who would like me to bring home some information about epilepsy. I know that most of the patients here are easy to treat, but I have a couple of them who are not. And you would like to know if those researches can bring some light into cortical malformations or epilepsy itself.
Anyone here in the room struggling with epilepsy wants to share some? We can also talk about the management in the next section. Other things that caught your attention in the last few days that you think should be there.
I just thought the linker protein gene therapy is pretty exciting, and happy to hear that that's progressing really well.
Okay. Why don't I throw up a list that I just kind of came up with before coffee, so it's So here's my list, and I want to start with something that is maybe not as exciting as gene therapy, but is an absolute requirement for making gene therapy and any transformative therapy a success. And that is, we have to be able to do it in all ages, basically. And so what you heard yesterday, that we had an outcome measure study, like a natural history study in children from 5 to young adulthood, and that was successful and was able to define outcome measures in this age group that we can use in a clinical trial. As you know, whenever we think about treating a genetic disease, we want to not, first of all, leave anyone behind, but on the other hand, also once we have it, to be in the patient as early as possible so that the disease can be modified at an early age. And for that, we have to consider to treat essentially from the time of diagnosis. When the disease is recognized in the future, hopefully as early as possible, in LAMA2 muscular dystrophy, that is possible if physicians are attentive to the existence of medicine deficient muscular dystrophy. So when there is a newborn infant or a young infant with weakness and low muscle tone, that at least they do a CK right away to see that the CK is elevated and not do kind of thousands of other investigations that are not sensical in that context. And an elevated CK with the right level of education should lead to a diagnosis very, very quickly. If genetic testing is available, which it will be, and clinical recognition is there. So ideally, we have a diagnosis really in the first few weeks to months of life. And then we need to, if there is a therapy that is on the horizon, or even therapy that's approved, we need to be able to treat as soon as we recognize something. But before that, we need to make sure that when we do a clinical trial, that we can do this clinical trial in this age group and also convince ourselves, but also the regulators, that the treatment is either working or it's not working, so that we can and so for that we need clinical trial readiness in that group of young children and infants. And we need to do a study to define outcome measures, meaning what are we looking for? We're going to look for different things. We're certainly going to look for different things compared to adult and school-age children who can cooperate with complicated outcome measure scales. So it has to be fundamentally different from what we do in older time. And ideally, we want to have what we call biomarkers, which are markers either in the blood or the urine or in some sort of imaging that tell us the disease is modified before we even can see it clinically. That is an important thing to make clinical trials more effective and faster. So that's my first research priority, and I would like to have researchers, clinicians, and in the room comment on ideas along those lines. Yes, we need the floating microphone, please.
Thank you. In São Paulo, we have been working on some tools and some scales, outcome measures to assess upper limbs and lower limbs. So MFM is the most common, but we have also another upper limb scale named RULE. It's a revised upper limb model that was initially developed to assess the upper limbs of SMA, but now we are trying to validate to this population. And we are constructing a protocol of measurements like strength, range of movement, and we appreciate if you have some other tools to contribute.
Yeah, so what that brings up, because Sao Paulo has more than 60 patients with deficiency. I was just in India and in Cairo, and there were many patients there too. So I think one of the messages here is to do this effectively and quickly, and we can take a trial ready. We have to do it in a network of sites that know the patients, know the outcome measures, and we do that not in a single site, but in a multi-site setting where we can validate. And that helps us also to validate outcome measures so that they function in different scenarios. So maybe one to do this would be to come up maybe with another ENMC or a kind of researchers meeting relatively quickly to define this type of strategy in the age group 0 to 5 so that we can do it quickly and internationally.
Sorry. Did Dr. Jim Collins do biomarkers years and years ago? Do we have, was that just preclinical, or it seems like I remember getting some blood and urine when she was teeny.
Yeah, exactly. Thanks for bringing that up. We did, and we also had from the Callisto study, from the omega study, we collected biomarkers for every patient in that study, before the drug, on the drug, and after the drug. And that's sitting in our freezer. And what we need is basically a little funding to do a biomarker discovery, where we can do basically large-scale proteomics and small RNA interrogation to get biomarker candidates from that. So that would be another thing to do this and then once we have a candidate biomarkers, we can then farm it out to the different sites and do it in very young children. Yes, that's all there and not gone bad, but needs to be analyzed.
It's still there.
Kirsten, are those samples that you just mentioned, are they tissues, urine, serum, blood, details?
So there are, tissue is of course something that we don't routinely collect. We have biopsies, a collection of biopsies where we did, it's not published, but it's finally analyzed. We did a big RNA-seq analysis of biopsies on very young children and older children to define the different stages of the disease on RNA-seq, which is a kind of a fancy method of reading genes on the muscle at different ages. And that can give us biomarker candidates that we can then monitor. What we've collected is serum and urine on every patient.
So I'm reminded of Matthew Dubuche's work in the DYW mouse, the mouse model of LAMA2 deficiency. And she was looking at RNAs in the serum, perhaps in the urine as well. And there wasn't a profound difference, by my recollection. And now that doesn't mean that's not the case in humans.
Exactly, because when we look at the RNA-seq that we did in human biopsies compared to the mouse, there's similarities, which is good, but there are also differences.
So I guess my next question is, or next comment is, when we see a change, say for example, we see an inflammatory marker in the blood, is that really predictive of disease progression? And will it actually decline in response to a given compound of therapy?
Exactly. This is having a seizure.
Can I talk about seizures real quick? Just briefly. So, seizures are not studied in the mice because we just not studied. And so, doing any preclinical work in a mouse model to understand seizures is just, it's going to be very difficult. And my recollection is that, and talking to many of the researchers that work with these mice, is that seizures are just not apparent in mice. And if they are, they're not recognized.
That's very true. And also the brain involvement, and then we can talk about the brain involvement in the clinical more, because that's a unique human thing as well. Now we're going to do an RNA-seq experiment as well, looking for disease modifiers, which are important to know. So Veronica has why don't you introduce her? Did you introduce your project? Okay, so, because I was in a different group. So that then will be very important also to define biomarker candidates. Because if we find something that's fundamentally different in a patient with mild presentation compared to severe presentation with the same mutation, then it means something is going on that protects a person from the disease, or in the reverse scenario, if you have someone who's more severe with a high mutation, something that doesn't protect from the disease and makes it more severe, and those are candidates as biomarkers that then can be fielded out into a much greater group of people. But those are very important early experiments to do this. And can that be modeled in a fish if you have a biomarker candidate?
Yes, so I work with zebrafish models, and we have a LAMA2 zebrafish model. Yes, if there's biomarkers, we can look to confirm those in our animal model, and it's something we can look for. And I think something that I took out of the work we heard about previously is that it looks like there are modifiers, and I think that's highly encouraging that it can be modified. And so that's something we can also try to search for in the zebrafish model.
Question about the zebrafish. I don't know if you can measure creatine kinase in a fish, but do they release creatine kinase?
It's a good question. We've not looked. So we tend to look for, we can see muscle damage, we can see impaired muscle function, we can see other signs of pathology. The fish are very small. At the ages we mostly study them. We're talking about less than 2 millimeters in length, so maybe a tenth of a millimeter in diameter. So very hard to get enough tissue to do those type of measurements, but it would be something we would like to explore.
So Understood. So, remind me, perhaps we can talk about this during the clinical stuff now in the session, but creatine kinase is elevated in LAMA2 deficiency, but it's certainly much lower than, say, Duchenne. What is your opinion of creatine kinase as a biomarker?
As a biomarker, I don't put much credence into it because it declines actually over the disease naturally as a muscle gets less able to release creatine kinase. And so if you just looked at that, you would think, oh, things are getting better, but whereas the reverse is actually true. But I think it's a good, if we think about newborn recognition, once, let's say, Duchenne is always leading the field because there's so many more patients, but let's say we have an effective or somewhat effective therapy, Duchenne muscular dystrophy, there would be great incentive to do newborn screening for Duchenne muscular dystrophy, and that newborn screening will include CK. And so that will discover Duchenne muscular dystrophy, but also there is sufficient muscular dystrophy. So that would be working for us because it will give us a sense of how many patients are there, how many patients are born, how do we best diagnose them, are we missing any patients using our biomarker for diagnosis, and how do we achieve, when we have that, and it's not Duchenne, how do we achieve a rapid diagnosis? Or even argue, if you have an elevated CK, don't just look at Duchenne, look at all the congenital disorders that can give you elevated CK, and I think that would be hugely important.
I would like to know if the mouse, no, not only the mouse, but the animal model, is it good for evaluating contractures? Because sometimes the severity of the contracture is not related to the severity of muscle strength, and that's definitely an issue.
Yeah, so certainly, when we look at contractions, I don't know if spinal curvature can be considered a contracture. I don't know, perhaps not. But certainly, if you look at how the animals run a cage, it's very stunted. They have a very poor stride, and there are methods and procedures and equipment to actually measure how these animals walk, therefore understanding if there's any contraction involvement in that as well. But again, translating that into clinical situations needs more work. But certainly we're expanding all the different ways we can look at treating the mouse. We are quite fortunate. The mouse model of LAMA2 deficiency is quite good. It models the human disease very closely with epilepsy aside. So I guess my question, I guess to the team here is, I'm quite interested in looking at all muscles across the entire lifespan of a patient or a mouse. And I guess I have a question to everyone is, how can we increase the use of MRI to look at all the muscles in an organism, a mouse, a human, across time? And the reason I say this is because biopsies are nice. They give you tissue data, but you have to pick which muscle you want to pull it out of. And what happens is that you are subject to what's called sampling bias. So for example, your arm may give you a bad signal, but your leg muscle may not give you a bad signal. And making decisions based on one sample may put you in the wrong direction. Some of the posters that were discussed this week, looking at MRI, you can clearly see changes in the muscle across all the muscles in the entire body. And again, what's nice about this is that you don't have to make a biopsy. And you can look at every single muscle without damaging them. The problem with MRI is it's expensive and not perhaps available to everyone.
Yeah, I can try to give some insight into that question because it's still relevant for the first point. We're only using that too much time. So we use muscle ultrasound. Muscle ultrasound has the advantage you can do it at any age, in any muscle of the body that is accessible to an ultrasound program. In an infant, in a child, you can basically image through it and completely. And that tells us two things. One is that, and we have to be realistic about it. It tells us two things. One is the muscle disease is established very early. If you do this type of ultrasound imaging, even in infants, you see every muscle is really affected at that point, without much of a pattern. So that kind of minimizes a little bit of sampling bias problems. But it also tells us, we are faced with a disease that's already ongoing. Even if we do neonatal screening and do the diagnosis as early as possible. So that's something we just have to be cognizant about when we develop our therapies. And secondly, for the MRI turns out to be as you mentioned, a very good outcome measure that's now accepted as as a surrogate outcome measure in Duchenne muscular dystrophy. And we have some pilot data and have submitted a grant for prospective study of LAMA2 with the group at the University of Florida who are doing the image DMD study that has left the field using very similar MRI technology to look at fat content, water content, inflammation over time. Caveat here is twofold. One is we don't want to do it in infants that we have to sedate, so we can't do it at this very early stage. So ultrasound may be better there. And secondly, the contractures, as they progress over time and the children get older, make MRI imaging more and more difficult. So we have to make sure the children are comfortable in the scanner and we can get meaningful images. But you're absolutely right there. Something that we need to develop among those as a biomarker. Any other comments from it? Yeah.
Hi, I'm from Barcelona, and we have a project to work with Paris and Chile about MRI in LAMA2. And we wanted to find some patterns and early patterns and correlate the infiltration of some muscles with the duration of the disease. And until now, what we find is that in some muscles, this is a real fact, that there are more infiltration with the time that the disease is going on. And well, we have to evaluate deeply the results, but we are really interested in this field.
Yeah, so that's great. So the more information we can gather, and I think we analyzed also together some early MRIs in relation to ultrasound, right?
Yes.
Yeah, that's good. Okay, so we should probably plan on the meeting to really do this systematically and get ready for the young children. So then my next, before we go to the genes, is to really understand what makes disease progress in muscle if there is no narrative around muscle. So in any genetic disease, you always have these, I have this little diagram, you have these three layers of therapeutic intervention. You can go to the top where the gene defect is and try to really either correct the gene or really do a fundamental correction of the gene missing, for instance, the linker approach. And then secondly, you have what happens in muscle if the gene product isn't there. So that the mechanism that play out in the muscle that drive in the end of the disease. The absence of merosin is the cause of the disease, but it's not really what destroys muscle. What destroys muscle is what happens as a consequence of merosin not being there. And those are the mechanisms. And I mentioned we're in a fortunate situation that we have mouse models of very severity that really are quite reflective of the movement disease largely. And that's good, and it's that, if you will, because it gives us so much things that go wrong in the muscle that we now have to sort through and decide what actually is important in driving disease. Because we can't go after every single lead that comes out of the mouse. We're going to spend our next 30 years chasing them. What we want to know is what is the most important driver of the disease? What's most upstream? What has the greatest efficiency if we intervene with that driver to prevent? It's almost like a waterfall. You want to be upstream of that waterfall to make sure that you capture as much water as possible and prevent it from going downhill. You go down, where the waterfall ends, you're not going to modify the disease. You have to go really upstream. So we have to understand what are the drivers and what are the drivers at what age. Because the mouse also tells us, and we have evidence from the human as well, that the disease drivers may be different at different ages. And so to be optimal in our therapies, you have to make sure that we target our therapy directly to where the greatest need is for the disease. And I've listed some of them: fibrosis, inflammation, apoptosis, autophagy, degeneration, and regeneration. Those are all things that came out of the mouse work. We already know that, for instance, inflammation from the mouse is a very early thing that happens. Fibrosis is somewhat later, so there is a hierarchy of disease mechanisms that we have to understand. And I want to interrogate our basic researchers here to see what they think about it and how we would go after it.
I just had a question related to some of the things that you're seeing in the mouse models when we're talking about the progression of the disease. What we've been seeing with our daughter is that the progression hits most after a viral process or pneumonia. So we're seeing a lot of deconditioning, an increase in scoliosis and contractures. So I know that we've got the waterfall, but are y'all able to replicate that version of deconditioning, or are you just watching the typical progress of the disease?
That's a really good point. I mean, there's probably two messages for us as researchers in that. One is, could in disease like an inflammation, a pneumonia, a viral disease, could that reawaken some of the inflammatory activity in the muscle, so that the muscle is now damaged by the inflammation that goes on in all the body, and then we should intervene there. Secondly, what's the role of deconditioning, but also of keeping the muscle conditioned, so that it doesn't undergo atrophy because of disuse or lack of use of these contractures. You want to comment?
Sorry, can you repeat
Well, the question is, the families have observed if the child is ill and doesn't move very much because of the disease, and everything increases very rapidly, the contractures, the weakness, the deconditioning. And how do we prevent deconditioning from happening and contractures from progressing?
So
We're already mixing in clinical care, so
you're not.
So the best form of prevention is to do a correct positionment for a long time. So we use orthosis or splints, night splints, that could maintain the muscle, including the internation, because sometimes when the patients are in internation, some families, go. Yeah, the hospital sometimes could be at the rear, or the families, relax for a moment because the patients it's with her, with the pain and hurting condition. But I think it's very important to maintain like a habit and use orthosis and pay attention on the position, and as well as a wheelchair prescription. So we have to prescribe and maintain the use of these equipments.
So I guess I kind of wanted to just bring attention to the research side of it too, because we've been in the ICU a few times with our daughter with different viral processes, and the orthotics is a wonderful idea. The inpatient PT is a great idea, but when you have a PICC line in one arm and an IO, and you're talking about intubation, and they're trying to position not in supine to get her the best relief, and she only wants to sit up, but she wants to sit up to the side. There aren't really great positioning techniques that are going to assist us at that point. So I guess the way I wanted to bring it up is that we want the research on the LAMA2 side for progress, but when our children are healthy, or at least in our model, when she's healthy, she looks great, and we're able to participate in all of those pieces of care. When she's sick and deconditioned, it's that really acute phase that's hard to figure out where we're supposed to intervene, how we're supposed to intervene, and are we capturing research in that component of care?
That's a really good question. And the answer is the research is not really capturing that. The mouse mites are great, but they also have certain disadvantages. The complete deficiency of myrosin in the mouse is really severe. And so these mice have a very limited lifespan. You can't really monitor aspects of the later stages of complete myrosin deficiency in the mouse very well, because they don't live that long. And secondly, they have a problem with a disability that the human patient fortunately doesn't have to that degree, which is a nerve problem in the legs that the mice have. So a lot of the strange mobility that the mice have already under the tightly contracted, the leg contractures are driven by a nerve disease that it exists in the human, but it's not as prevalent in terms of causing disability, at least not at the current stage. So, answering the question, no, we don't have a really good handle on onboarding that number. You should do a better job and try to do that, but also be cognizant right on the clinical observation that you said that it's important to, even in these dire situations of severe illness, to keep things mobile as much as we can and rehabilitate as quickly as we can. And there's a little piece of good news in that too, though, because you notice, I hope you notice that sometimes when things get better and the kid comes out of the hospital and you start up your therapies again, you start the mobility again, not everything is irreversible, things come back, and the muscle recovers to some point. That's good news actually, because it means it's not just kind of a step down and no recovery. There is some flexibility in the system. Wait, so is the fish have any use notice? Because fish are good because they are much bigger than mice in terms of research results.
As well.
So I think for the disease modifiers, the fish can probably be of use there. It's probably the area they can contribute most. We previously, for other diseases, done screens for drugs that promote autophagy, for example, with beneficial effects, and that's something that could be repeated in LAMA2. Inflammation does happen in the fish model. The immune system is slightly different in the fish, but it could be addressed, but definitely things like the proteome and autophagy would probably be the things I think could be most readily addressed, and it's something that I'm taking away from this meeting that we should be looking at.
Yeah. Maybe one message is also to integrate systems. So we have to integrate the mouse data, the fish data, and the human data in real time, basically, to decide what the hierarchies are. So all of these, some of these have actually already have good solid mouse work behind them, and so some of them may be worthwhile to follow up. At this point, probably wait for the more transformative treatments to get. Because again, I think one thing that we really should take away from this is that one therapy will not be enough in this disease, because it's a tough disease. It's an early disease. It's a disease that is progressive over time, and you have to be I call it multimodal. So you have to try to hit as many disease-important aspects of the disease as you can, from modifying the gene, modifying the downstream effects, making muscle more resistant to the disease, because none of the upstream, so the genetic therapy will ever be perfect, and the disease is already ongoing. So you have to help muscle to make the best out of the genetic therapies that you can. That's why these secondary are not as sexy as maybe a gene therapy. They're extremely important to not lose track of, to make sure that the muscle can recover. And fibrosis is scar formation in the muscle that happens here. We know from other systems it's not irreversible. It can be turned over, and we have to promote that and help it. And as we do regeneration is inherent in nerve cell deficiency, but there are tricks and ways to help regenerate better. So all of these need to be part of it. As you know, if you have a family member with cancer, for instance, you will notice that person is never on just one drug. It is always a mix of drugs. It's always multiple to help attack as many targets as possible. Great, and so that brings me to that point here, which is a point that is, I think, of great importance in all of muscle disease as we treat degenerative muscle disease, muscular dystrophies of any kind, is how do we get stuff into the muscle that is already transformed by the disease with scar tissue and fatty tissue in the muscle. It's not a normal muscle anymore, and so the access to the muscle may be impaired by the disease process itself that you want to modify. So we have to pay great attention how we get things actually into the muscle that is already diseased, be it a gene, be it exon skip, be it a protein. We have to model that, and it doesn't only apply to myosin deficiency, it really applies to our dystrophies because it's good, because everyone hopefully thinks about it. I wonder whether there's any comments in the research community.
Yeah, I would like to comment on first fibrosis. So a few years ago, I did a review of fibrosis across the congenital muscular dystrophies, and my conclusion was that fibrosis was perhaps the easiest to reverse congenital muscular dystrophy. That's just based on published data. But in terms of making the biggest impact on disease, I would say that stopping apoptosis or cell death is probably the biggest thing we have to do. We need to stop existing muscle fibers from dying, from killing themselves, if you will. But on top of that, we have to re-stimulate regeneration. Because of LAMA2 deficiency, the satellite cells and stem cells of your muscles poorly regenerate. It's incomplete, it's often aborted, it takes a very long time. So that gives us, to reverse that, gives us the ability to build new muscle when muscles are dying. But as you said, Carson, when things transform, so when you transform a muscle into, say, a fatty tissue, it's very difficult to change back from a fat to a muscle. So this is where we have to work as soon as possible into patients. And last question, sorry. Inflammation. Has anyone looked at deflazacort or other anti-inflammatories in LAMA2 deficiency?
Yeah, I have only a few experiences with that, and they were too late in my opinion to really influence that. It seems, my feeling is that inflammation is a relatively early occurrence, and I have had experience, I don't know whether that's your personal experience in your family, but I have seen a number of infants who were floppy at birth and but were still able to lift their legs up, like many nursing kids can do, they can just kind of lift their legs up. But then that was lost, in the first year of life. It just kind of went away, and then then there's another picture. I think that's the inflammation that's kicking in there, really. Do you want to comment on that? That's what I say. Yeah. So, and I think we have evidence from the very early onset data in children below 1 year of age, and that is indeed happening. And we may have to be more, and we were trying to figure out, as this which we did in the mouse models, we're trying to figure out what the type of inflammation it is to be more effective with our therapies as opposed to the sledgehammer of steroids. That is a really good question. Okay. So then we come to the gene-directed work, or the missing protein again. One word about the apoptosis again. Are you all aware from the omega-3 trial that there is an anti-apoptotic drug that went PK studies but is not yet tested for efficacy, so hopefully that will happen. Apoptosis is an interesting phenomenon that happens in the congenital muscular dystrophy because congenital muscular dystrophies are disorders of the muscle matrix. They're disorders of how the muscle talks to its extracellular environment, what's around the muscle. And apoptosis is actually fundamentally a good thing because the body came up with that to get rid of cells that are no longer needed or that could actually be dangerous. If you think about cancer, for instance, if you have a metastasis from the cancer, so a little piece of cancer that goes somewhere else and wants to establish a new tumor, the body wants to prevent that. The genetic makeup of the body wants to prevent that. And it has a built-in kind of emergency brake that tells the cell to shut down if it's not in the right environment. So the matrix, the extracellular matrix, gives the cell signals and to say, yes, you're in the right neighborhood here, flourish, be good, but when you get into the bad neighborhoods, then the cell says, whoa, what's going on? I better shut down. And that's called apoptosis, or I know this in a fancy Greek term. But in the congenital muscular dystrophy, what happens is the environment of the muscle is fundamentally different because the connection of the muscle to the matrix is no longer there because the laminin tumor on the nerves isn't doing its job connecting the muscle to the matrix. And hence, the muscle doesn't get the signal it needs to be flourishing. That's what drives the apoptosis. So you could do something like a medication to make the muscle more resistant to apoptosis and kind of not allow you to pull the emergency brake too quickly, and so then that would prevent apoptosis from happening. But of course, the best thing would be to reconnect the muscle to the extracellular matrix, to give it the right signals back to not undergo degeneration. And so that's what these last approaches are trying to do, where you say, well, I know that muscle is not connected to the matrix. And I can connect it to the matrix, reconnect it to the matrix even if LAMA2 isn't there. So that's what these approaches are based on. I want to reconnect the muscle to the matrix. And you heard about the dual linker approach yesterday, where one takes a laminin isoform that's there but doesn't have the business ends to connect muscle and matrix, and provide it with the business ends, that's spare parts basically. That's the dual linker approach that you did, I think, yesterday. We have basically custom-made body-owned proteins. You take spare parts from the body, you custom-make them into something that just does this new job. And you can deliver it with gene therapy, with 2 gene therapies to do that. But the effect is to re-establish a link with spare parts to it. There is another chain of laminin, which is called the laminin alpha-1 chain, or LAMA1, which looks almost identical to LAMA2, and the body has it on board. It has the genes for it, but it doesn't make it around the muscle anymore. It only does certain development early on, but later on it replaces naturally LAMA1 with LAMA2. So like LAMA211, which is medicine. But there's very good work from a number of different laboratories. If you were to have laminin alpha-1 to take the place of laminin alpha-2 to make a laminin 111 instead of 211, then that would be established the linker as well, because it has the business ends now that are needed to connect to the muscle and to the matrix. So you can do that with a number of different ways. You can say, well, the gene is there in the body, but it's not upregulated, it's not turned on where we need it. So we find some tricks to turn it on where it's needed. Very similar to the work in Duchenne muscular dystrophy, where they also have a makeup gene called utrophin that doesn't do its job after birth. Where people try to upregulate, switch on the gene of utrophin to make up for dystrophin. Same concept here. We have a backup gene in the body, LAMA1, where we find a way to turn it on in muscle, then it will take the place of LAMA2 and create the smoothing. So that, if you talked yesterday about the CRISPR-Cas9 approach to do this.
We discussed it briefly.
So there's genetic tricks to do that with a version of CRISPR, a non-cutting version of CRISPR that just delivers a tuner to the gene, and the tuner of the gene will tune up the gene to make more of LAMA1, using this kind of fancy tool of CRISPR. You can also think about maybe there are small molecules out there that would do the job as well, that would be going there and tuning up the gene. Maybe we should find a platform to screen for drugs to the molecules that are able to tune up LAMA1 instead of LAMA2. And then finally, we can think about delivering the entire thing as a protein to the body, which is the protein therapy that you talked about yesterday. So maybe we can get some comments, ideas, questions. Yes.
One regulation that article that was put out last week from the people in Toronto. It seems to be working for they talk about positive working for other multiple muscular dystrophies as well, because you're not focusing on the two and having them come up with different corrections for that, because there's so many different genes and so many different ways that they're modified. So this kind of corrects a lot of vast majority of them, and also it talks about reversibility, potential to reverse some of the muscle damage, and actually I've talked with Dr. Cohen in Toronto, and when I had Mike when he was 6 months old, he was talking about that they were working on the Cas9 and the CRISPR for splice segmentation. So he was like, well, you know, that your particular condition isn't exactly what we have right now, but we're working on something else, and then this was apparently something else that they were working on. So they moved really quickly. I mean, it's been maybe a year or so, and the progress. I mean, the linker protein is great too, but it seems like that's been in development a very long time, and also it wouldn't have the potential of helping other dystrophies, which would in turn help you get more funding, and also I think, correct me if I'm wrong, with the linker protein, it seems like you have to give it enough protein for it to last as long as it's asked to produce the protein. Is that, I'll let you talk more about that.
Okay, do you want to take a first step and then I'll take the second step?
Yeah, so I mean, in terms of duration of treatment, certainly we want this therapy to work forever. And for gene therapies, you typically get one shot to treat the patient. And so you want that first shot of gene therapy to, one, hit as many muscles as possible, secondarily, express the LAMA1 protein to a therapeutic level. And so, in the absence of any immune response, it should last forever. That's one of the issues. I think it's a predominant issue with gene therapy is how long will it last? And so again, we can discuss relative merits of gene therapy and protein therapy, but the point is the drug, whatever you use, must last a very long time. And so that's something we can think about, especially when you think about gene therapies, is the role of the immune response and actually neutralizing the actual drug you're making. And just on the flip side of that, the laminin protein therapy approach, because it is a natural protein in your body, it would last forever, but you have to have it delivered every 2 weeks or every month, or perhaps every 2 months. We really don't know how long it lasts in the muscle.
So that brings up two important questions. The answer of which we don't know for any of these three approaches is how efficient are they going to be to deliver the goods to make a difference in the disease. And that requires really to try and to do it. So therefore, I think I wouldn't say, we're going to ditch two approaches and just follow one. I think the preclinical work should continue in all three of them very clearly. Let me just kind of make a comment on the gene therapy side of things. So the gene therapy is, if we do gene therapy in a young child, we have to consider that we have to redo the gene therapy at some time in the future, because and that probably is true for most of the therapies we're discussing, because children are growing, the muscle is turning over, and the gene therapy, even though once it's in a cell, it's probably good forever. Once the cell divides, the gene therapy is not inherited to both of the daughter cells when the cell divides, so it can dilute out as more cells are formed, because it's not inherited, it's just proprietary to the cell that got you. So that's an important point, but it's not insurmountable. We can think about ways and means, and others are trying to bring ourselves in infantile muscle disease to create an immunological environment that allows for redosing at a later point in time. Because we want to prevent immunity against the AAV. Now, the delivered good, the linker protein has its own immunological consequences. And I think the good news for both the LAMA1 and the linker protein is that they're fundamentally body-owned proteins. They're basically proteins that at least hopefully the body has seen before the immune system will tolerate to a large degree. So that's an advantage of that. AAV gene therapy in general has the advantage that it's really a somewhat simplistic approach. You have a delivery tool, if you will, a male pigeon, an envelope that is good to deliver to muscle. And the knowledge about AAV that's gained in one muscle disease is good for other muscle diseases as well. So we're gaining as a field more comfort and knowledge about AAV, meaning that it could be closer to clinical application than, for instance, a CRISPR-Cas approach, where we have no comfort and no knowledge how the body would react to CRISPR-Cas at all. So there are kind of those considerations as well. How close are we to clinical translation, but also how good is every single approach going to be in delivering the right quantity to ameliorate the disease.
I have two questions. We hear AAV delivery a lot, with many different types of potential cures or treatments. Is there any concern with the effectiveness of AAV over time with it being used so widely that it may become forced by the body?
Yeah, so that probably starts actually earlier. The AAV that we're using is, so the principle of gene therapy is, of course, you take the virus envelope and you take out the viral genes and make it kind of cause a viral infection and replace it with what you want to deliver. But the viral envelope is the same envelope that this virus will have in nature as a virus. These viruses that we're using, the AAV viruses, are essentially non-pathogenic and don't even cause a disease in humans, but they infect humans. So a certain part of the population, up to 30% at school age, will be immune against the AAV just by natural infection with it. And then you can't do the treatment anymore. In an infant, you have the luxury of an infant being probably not yet exposed to it, and so there's a great opportunity. But you're right, once you immunize either naturally or by the therapy, you can't do it.
The second question is, I think when everyone finds out that their kid has LAMA2, they think that all kids are the same, they have the same mutations, and that the treatment for them all is the same. We found out the mutations slightly different than other kids, and the effect on another child is different than the effect on other children. Which of the therapies that we are talking about would fall under personalized medicine, and which are more generic, which could actually impact and help the whole population?
Really good question, and the answer is all three of these are applicable to all mutations, so that's the good news. Because they're ignorant to the mutation, they just deliver a new linker, be it by protein, be it by upregulation, or be it by dual linker therapy. So irrespective of the mutation, complete, partial, it really doesn't matter. The approach that you mentioned, that Ronnie Cohn had done earlier with the CRISPR has, that's personalized medicine. So for that, you need to know exactly the mutation, and you need to design the tool to tackle that mutation specifically, and then it really counts what mutation you have. So these are more broadly applicable and ignorant to the mutation. That's the good news about this. I think we need to move on to so I think we have a nice list of things here. There's a lot much to do this, but I think it's one that is getting more and more focused, which is nice. Any final questions on this?
I'm loud enough. Thank
Actually,
you for that comment.
we've been using my, yeah, for recording. Thank
Thank you for the wonderful talk and covering all the important topics, and all the researchers as well for doing their phenomenal work on animal models. Forgive my ignorance, but I just need your input or comments on how relevant or how appropriate is it to extrapolate mice model studies to humans, the data that you get from mice. And the reason I ask is, we did a study, there was a publication on mice models of DMD that showed delayed transit as an example. We did it in humans, in DMD patients, and we didn't find any trace of that transit. So that's just a small example. And the other point in the case is, there's been so many pharmacological agents that have been tried in animal models that seem to work, or maybe they never work in humans, along with gene therapies and protein therapies. So could you comment on that? And are there specific areas of research where animal models prove to be much more, robust?
Yeah, I mean, that's a super relevant question. And as Brad was pointing out earlier, I think the LAMA2 field is in a slightly better position than the Duchenne field in that the mouse models, so it's a number of mouse models that are used in nerve deficiency are really better models of the human disease, and they're tougher to treat also. MDX mouse, Duchenne mouse, is actually treatable by lots of things that never translate to the human for many, many reasons. Part of it is that the disease model isn't very good in terms of the severity of what actually happens in a big human body. The medicine, we shouldn't kind of be naive about it. The medicine deficient mouse is also a mouse, not a human. So with all the problems that come with that translation. However, my take on this is always you have to ask the right questions of the mouse. You have to ask what is a relevant biomarker of the disease that I need to move with the mouse before I even can think about translation. So that's a question I would ask a mouse. I wouldn't ask the mouse to be a complete stand-in for the human disease, but I would, that right question and answers the right question. So kind of a stop-no-go decision. If you can't do this in the mouse, you can't move this biomarker in the mouse, don't even think about going to the human. But if you do, then you have to think what's different in the human and what we need to achieve in the human. That's my takeaway. Same for other models like fish, cellular models. You always ask the right question and ask yourself, is this question relevant for the human disease, even if I answer it? And that's why I think the integration of human preclinical work, mouse and fish preclinical work always has to happen in integration. We do it step by step. We're going to lose out when we translate to the humans because we have ignored fundamental questions before. And then there will be a step when you have to go to the human. And that's the final answer. But we want to only go into patients with something that we have a high level of confidence that it will actually do what we wanted to do. It's got a hand waving, but I think that's a little bit, I don't know what
I think that's an excellent point, but also an excellent question. I think it highlights the importance of the first item on this list of identifying biomarkers in the human condition, because at the moment, if we're using markers we've identified in our animal models that aren't also markers in the patient population, they may be of less utility. But if we find markers in the patient population and then look at those markers specifically in the animal models, whether that be the many different mice models or the fish model, then that would hopefully improve the translation of that. And of course, looking at multiple mice or multiple species, we would hope to see consistency that might suggest greater chance of translation.
Is that also very simply, the closer you go to the actual problem, the closer you go to the ultimate biomarker, the gene defect, in the linker, the better it's translatable. To go downstream to autophagy, apoptosis, even, and then species different play much more of a role, and then you get less and less confident about translatability.
Yeah, I'm just reminded of the differences between mice and humans. I mentioned earlier, there are severe peripheral nerve defects in the mouse, which are not apparent in the human. So, looking at nerve defects in a mouse may not necessarily translate to human treatment. The lifespan of the LAMA2 mouse is actually quite short, and that's not the case for humans. So you're right, we have to, look very carefully at what aspects of the mouse can translate to a human outcome. And I was just going to say, that's something that we just need to think more about. What's the list? What's the hierarchy of important translation events in the mouse that we think will best translate to the human condition? And you're right, Carson, things that are directly connected to the gene defect, the primary defect, will have the best translation. And looking at downstream events such as inflammation or fibrosis may not translate very well.
I don't know if this is the best section to talk about it, but in general in the research, how much of this data is making it to public data repositories in order to leverage some bigger data techniques? Because it's such a small population, we need as much data out there as possible.
Most of it does maybe, so whatever's NIH funded, for instance, is going to be obligatory in the public domain. And I hope once we go, and unfortunately this is a very friendly collaborative researcher field, so information is shared between researchers very freely. There's less of the bad cardiologists or cancer people that we are talking about. So that information is shared. One thing that's very important, though, we bring up a really important point. Once we get to translation and we have commercial entities and industry involved in this translation, we have to have code of ethics that particular safety data that are relevant to the entirety in real time, so that there's no danger to the patient and things can be done as safely as possible. So there can be no siloing of that information. The field is too small. It's a really good point.
I'll just say something on top of that is that unlike the Duchenne field, which has just an army of folks behind it, the congenital muscular dystrophy field is rather small. There's really only a handful of scientists in the world that work on the mouse. And we need to achieve a greater critical mass of folks to accelerate things, to do the data sharing you're talking about. All the data's out there, but we just need people to really collate and curate that data more effectively. Carson's
Yeah. So let's move on to Pini. Do you want to start with the epilepsy question, or we can also take questions from the audience? Let's see that.
Yeah, so moving a little bit, transitioning a little off the research to care. Kind of started with your question. This is too much, but you mind maybe start with the end.
So I asked before about epilepsy in portfolio of patients and how does this research, you can imagine how it's going to have some effect on that. And so I can bring into light this question and bring home some of these answers, because on our cohort we have patients who suffer from the drug-resistant epilepsy.
And so if we want to segues a little bit from the biology into that, so I don't have a good answer to that. Like with many epilepsies, once you are starting to be resistant to the first two drugs, you're probably resistant to drugs too. And I have no pathogenesis driven answer to what the best drug is. It really is probably pathogenic diet. You have to be fed through. The origin of the epilepsy is interesting in that it almost always comes from the back of the brain. So the visual brain is the connecting part of the visual brain. And so what you often hear from patients is that they have an premonition of seizures, which are often colorful phenomena. So several patients who would say, well, my red balloons are coming, and then the seizure will take place. Often it's not a seizure that you know is a core mild seizure, where the patient goes with this kind of shaking. Often it's what we call a complex partial seizure. So it kind of starts with this premonition of visual phenomena, and then the patient will just lose contact with the environment, and they'll just space out and not responsive, and can't be talked to, and creativity, eyelid fluttering, autism, ability of drooling. And those are signs of these type of seizures that parents and families need to be alert to. So any young child will daydream and expect, they're just going to go off in their thoughts, and then that's a very normal child thing. But you take the child back there with a nice chocolate bar, it's interesting. But in a seizure, that's not possible. So you can't interact with the child during the seizure. So it's a completely zoned out state that you can get to. And that's an important definition of when EEG needs to be done. And it's wise to start epileptic medications that are directed and focused seizures. So the origin of these seizures, as I said, is in the back of the brain. And if you look at MRI scans from children with myosin deficient congenital muscular dystrophy, what jumps into your eye mostly is the difference in the white matter. Everything in the white matter is white, which is not a leukodystrophy, it's a neurodegenerative disorder of the white matter. But when you really look carefully, many children, more than I had thought, perhaps in our series, as many as a quarter of children have a difference in how the cortex, the brain is built in the back of the brain. And that some nerve cells during development don't make it to the right place in the brain cortex of the back. It doesn't have any, interestingly, it doesn't have any impairment of visual function, because this happens so early on that the brain neglects it. The brain uses other brain parts to provide visual information. We tested actually children with this brain abnormality in the back of the brain very carefully for visual deficits, and now none. It's completely remapped. That's the advantage of a very young brain. If that brain isn't available, you use a different part of the brain. However, there are miswired nerve cells in the back of the brain where they didn't reach their places, and these miswired nerve cells, they can fire off randomly and articulately, and that causes epilepsy. And it seems, even if you don't see this on an MRI scan, that still there is a potential of miswiring back there in the back of the brain that is the focus of these seizures. So that's
We have really poor pulmonological care in North Carolina, at this point where we are in Charlotte. So this question really hasn't been answered for us. Our daughter has shown no seizure activity at this point. She is almost 4 years old. We go every year to cardiology. Her heart looks great, so the comorbidities don't seem to be affecting her. Is there a generalized time of onset, or if we're not seeing it at this point, will we not see it?
So, actually in Brazil, we have patients with epilepsy too young. That's not usual, but usually what we see is after the first decade of life. So starting the second decade of life, it's more common to see epilepsy. So the parents should be aware. That doesn't mean that the child didn't present it before, that we shouldn't pay attention to other signs, like it's a child who always went super well in school, but now it's not that good, and it seems to be some sort of attention issue that could be epilepsy.
Good point. And I just have a question related to the my earlier question. Do the LAMA2 division mice have seizures?
Question is, have we looked hard enough? Probably also not, but not here. But to answer another to it, to just comment on this. So the fact that these seizures may occur later in life does not mean that there was a progressive brain disease, because the maturing brain changes over the ages, and in certain periods of brain maturation, seizures can come out more likely, just as a part of that. So it's not a brain degenerative phenomenon that happens. But it's a really good point. If you see that these seizures should not be, so this brain malformation or whatever the miswiring in the back of the brain should not be associated with any cognitive or intellectual or school problems. But ongoing seizure activity that's untreated may, because there could be electrical activity coming from that part of the brain that screws up other processes in the brain, and that gets better again once you treat the seizures. So yes, if you see either these kind of spacing out episodes, or you're trying to I'm seeing these balloons, these kind of weird things, what's going on, and that goes away. That could be a sign of very early seizures. And then it's important to find good neurological care to do an appropriate EEG. Sometimes EEG has to be prolonged to really capture these episodes.
Yeah, just from practical experience, so I just kind of piggybacking on what you said is that so Ashley did not have any seizures as she started going through puberty, and she had a seizure. It was probably the scariest thing we've ever seen. All of a sudden, your child is convulsing, doesn't look like can breathe, and it just took the entire family through a whirlwind at the time. So I think the big thing if you see one is to kind of understand what it is. And the eyes roll back in the head, difficult breathing, it's really pretty scary. And so the thing is not do what we kind of do, which is kind of freak out, call 911. We had like every police officer and all of Forest Lake, Minnesota come to our house. And then she was done. So we had a couple episodes, we got her a low dose of Keppra, and as long as we maintain that, we're talking I think 2.5 millimeters, it's very small amount, and she's been fine ever since. But from a care perspective, I just think that's very important to notice those signs. And so I just had to.
Keppra turns out, by the way, Keppra turns out to be a good first-line drug.
I was just going to mention, Owen is the exact opposite. He just stares. He's 15 and he doesn't have the full full seizure. He just stares. And he has had attention issues in school over the last couple of years. So it could be that severe to just, looking off, and he looks up, it looks like he's excited about something sometimes. He just looks up and, it's like he's, I don't know, he sees something, he's, a story in his head, and he just gets excited, and that's actually a seizure. So that's something to look out for too. Is he checked regularly? No.
That's why I have been asking so much about this, because it comes to a point when a child has drug-resistant epilepsy that is a bigger issue than muscle weakness. That's why I have been asking.
And the other thing I should mention is this can happen in both complete as well as partial motor deficiency. So it's not dependent.
One of the comments I wanted to make for parents of younger kids, one comment I wanted to make for parents of the younger kids.
Take two.
Sorry, and take two.
There we go.
And I didn't know if you could elaborate on this at all, because our daughter's 7.5, she's not had a seizure yet. But we were aware of this and looking out for it, and when she was younger, she had a glucose crash, followed by several, and I mistook it for a seizure. It terrified me. Some of the symptoms were similar. That's something I know that some people have faced, and I thought maybe it might be helpful for younger kids.
Yeah, thanks for bringing that up. We actually did, together with QCMD, a survey to see that it actually is a phenomenon that occurs in early onset muscle disease, perhaps even a little bit more commonly in myosin deficient and muscular dystrophy at a young age. So what happens in a young body, so blood glucose, of course, is extremely important to feed the brain. The brain feeds on glucose, and if you have low glucose, then the brain will be impaired to kind of drowsiness, but even to seizures that can occur. And of course, the longer the period of fasting is, the more likely that happens. And there are stores in the body to make glucose, and the most important one is the liver. But the next important one is muscle. And the liver needs to mature, and young children have much less liver sugar reserve, and they need more glucose made out of muscle. And the muscle is really low in children with congenital muscular dystrophy. They have smaller muscle, and they have muscle that doesn't grow. Hence, their glucose, their sugar reserve, to make sugar when they don't have it, actively eating, is low. And when that doesn't happen, of course, after long periods of fasting, or when the child is ill, and the intake is less good. So those are the critical periods, and we have a number of families where exactly this phenomenon happened in the early morning hours. Child was difficult to awake, wasn't quite responsive, even had a seizure, rushed to the emergency room, and very low blood sugar, that immediately responded to supplementation with sugar. So one has to be aware of that, so by making sure that, particularly during illnesses, when the child has less intake, sugar is always supplied, even during the night, as a kind of nighttime feed during the night, and also to make emergency rooms aware that this can be seen in this disease, because we've seen kind of crazy workups for hypoglycemia over weeks in the hospital for exactly this phenomenon in neurologists as a muscle disease. So the result of this little study is now accepted for publication, will come out and will be available to everyone. Super good job.
Just while we work on the mic transfer, there's just a quick question in this the world of seizures. So James is almost 2. He hasn't had a seizure that we know. From what we understand, he's probably younger than the population generally that would have seizures, but he's much younger than children. But there have been moments where, clearly he just spaces out like a 2-year-old would. There have been moments that have concerned us, and I guess I'm still not clear. Maybe this isn't a clear distinction, but is there a line that we as parents with a young affected child can clearly say he's crossed the line into what we think is a seizure? There were moments where he spaced out for longer than we're comfortable with. His face freezes. He drools pretty naturally anyways, but of course he was drooling and it was concerning. So still not clear what that distinction is. Maybe there isn't a clear distinction, but if you could comment a little further on that.
Yeah, sure. I think it's important to be aware that this can occur, and you're aware, but your caregivers may not be aware. So one thing that you need to do is, of course, kind of say, well, I don't want to cause any panic, but I'm observing this, and I know there is a 25 to 30% incidence of seizures in this population. And here's what I observed to a neurologist. Sometimes it's also helpful to take a home video, an iPhone video of the actual event. That's been more helpful than you would ever think. If you bring that to the office and the neurologist looks at how the child looks like and how it reacts to your intervention and trying to get the attention, they will be able to determine whether this is suspicious for a seizure. And if there is clarity about it, then because there is a known incidence of seizures, you would do an EEG more readily than you would do in a normal 2-year-old. So I think it's great that you're aware of it. It's also great that you don't panic, but it's also important to bring it to your caregiver's attention, in particular of neurology. With video documentation would be fantastic.
So my question has to do with hypoglycemia and seen in about 20% is reported. Is there any way, that's a big number, 20% is a huge number, so.
No, we don't know the absolute incidence, but it's somewhere, yeah.
So,
No, that's a seizures, but hypoglycemia. Yeah.
so is there, I guess my question is there a way to prevent that? Because they don't have muscle mass, is there any way of facilitating hepatic gluconeogenesis or glycogenesis in the liver? Increase the stores there vis-a-vis the nutrition.
There isn't really a good way to do that, but so I think that it actually varies in severity. We do have maybe 1 or 2 children where it was a real problem, almost like a disorder of gluconeogenesis, you know, like that. And then you have to follow basically the dietary rules of disorders of glucose production, that are liver disorders, so called, you know, genetic disorders of glucose. And those are frequent high carbohydrate feeds that kind of make up for the liver. And that usually works, but really prevents. And also, of course, to have your rescue orange juice or sugary solution, because if you know the child isn't waking up in the morning, that's the most likely thing for that to work.
Way back, she's got a question.
Hey, I just wanted to ask, my daughter is 5 and she's never had a seizure before. How often would you get an EEG for a child that hasn't had a seizure?
Not routinely.
Not like yearly?
No.
Just
because it wouldn't really do anything with it. If they, let's say there's mild abnormalities on the EEG, there are kind of different waves and so on, we wouldn't necessarily, we wouldn't treat them. We don't treat EEGs. We only treat when there is an actual seizure. So just be aware of it, but don't do routine yearly EEG monitoring. Is that your question?
For the patients with hypoglycemia, have you ever needed a gastrostomy for treatment? Because I have one patient who needed it because we couldn't treat it. He had it so many times.
Okay, I think yeah.
So Owen does have hypoglycemia, and we manage it with small meals. But how do we, with increasing in carbohydrates, that's also increasing carbon dioxide. So how do we balance that?
No, it should. Frequent sugary kind of snack will not increase your carbon dioxide. Yeah. So you mean like building up as a respiratory insufficiency, or is that?
It was mentioned yesterday that I was asking about nutrition. I was specifically asking that there was one of the breakout sessions on Thursday where they mentioned that a high-fat diet in SEP N1, that a high-fat diet can cause problems with the diaphragm. And so I was concerned, is that something that would be for all of our group? And then when I asked the question, they said no. You know, just stay, if you want to stay away from carbohydrates, because carbohydrates increase carbon dioxide. So I was asking for
I have to double check with them, but that wouldn't be that was inside, right? Maybe they need to clarify that. Because the carbon dioxide is the buildup is really completely driven by the respiratory system and not by the glucose intake.
If you improve your nutrition, that's what I was trying to get at. If you improve your nutrition, there will be increased glycogen stores in the liver, which is reserves. So when the blood glucose goes down, that will bring it down from the liver and raise your blood glucose levels. So
And that's
the importance of
fortunately gets better fortunately gets better with age, of course, as the liver levels. But not the carbon dioxide. Can you report to that? Make sure.
So I know that Keppra is the first line drug in our hospital. That's typically how they're treated in the ER as well. Are there any other medications? And I know there's lots of different thoughts on seizure medication and seizure disorders, but for this population, is there any, and I know there's a controversy with CBD oil as well, but is there anything that you've seen that is your best choice for LAMA2 treatment?
So I've seen patients well treated with oxcarbazepine and also with lamotrigine. with good results.
Yeah, so the bottom line is that's true. The bottom line is if you have two big seizure categories, and the drugs break down a little bit along those lines, generalized seizures and focal seizures. So here we want to go focal seizures. The drugs that are first line for focal seizures are the first line drugs for this. But sometimes you go, unfortunately that's a phenomenon in epilepsy that's not clear. Once you're resistant to the first 2 or 3 drugs that against really trial and error, and it goes down to ketogenic diet and all. Exactly.
I have anecdotally one patient that used CBD. And it's not on the papers that CBD is good for focus.
But it's not good for focal seizures?
It's not
Don't
proved
know
to
yet.
be good. It's not proved to be good.
Can you just repeat the drug that you just did?
Oxcarba, but I had yes. So Tegretol, yes, that's the pharmaceutical name, and also LAMA2.
I gotta get a plane soon, but we appreciate you hanging out. There was a study, I can't remember out of which country, where they were trialing the use of metformin on kids with LAMA2. I haven't seen any follow-up from it. I'm not sure if you guys have reviewed the findings of that one.
I haven't really followed up on that either. Metformin has a kind of spot in the sunlight right now, so it's kind of trying to almost every disease. So one has, I think, have a high level of skepticism there, but I haven't really followed up on it.
We've done some studies in animal models and we find metformin good for a different myopathy. Metformin has many different roles. It's obviously best known for its role in diabetes, but it does many things, including affecting autophagy, which was mentioned earlier. And so there may be a connection, but it's really hard when these drugs have so many possible functions to know exactly what it's doing. So it's certainly interesting to follow up on, but I don't think we know yet.
That was a really good discussion because it was all LAMA2 specific.
So this is more of a broader, maybe philosophical question, but
for the end.
Yeah. This will either stop us in our tracks or keep us going for another hour. Any thoughts on properly managing the condition and balancing quality of life? We ran into it recently with BiPAP machine. He's got a trilogy ventilator for BiPAP assistance, and he just didn't adapt to it very well at all. He hates the mask, he can't sleep with it. He's just now getting used to his cough assist, which we've had for almost a year and a half at this point, and we use pretty regularly. So he just was averse to using the mask, he really didn't like it, and we had a conversation with his pulmonology team, and they basically said, let's just hold off. He's still kind of young. The data they were seeing didn't suggest it was a severe, having severe apnea episodes. His CO2 levels, we didn't get a great reading, but I didn't get the sense that there was a kind of concern there. But maybe just in general, we talked a little about seizures, we talked about some clinical trials and treatments, but just some thoughts on, as parents and as families that care for these affected kids, how to manage the quality of life versus the care that's necessary.
And many in the room are much more qualified to comment on this, in particular family with children who have gone through this, or Stephanie as someone who has gone through this for life. And so I want to get some, this is a great question, I want to get some comment here.
I can speak for the BiPAP itself. We actually knew that Micah was having problems, and I wanted to say something in the pulmonary section yesterday, because it was brought up that a lot of times it's like 2 or 3 years old that these kids get BiPAP, and I disagree. And honestly, the only way that I knew that he needed BiPAP is because we had a pulse ox at home, which brings me to another question, why a pulse ox isn't like as soon as you get a diagnosis, everybody gets a pulse ox. As soon as you get a diagnosis, everybody should have a cough assist and suction machine as well, in my opinion. And also, recently, I don't understand why, as soon as you get a diagnosis, you don't get a glucometer at home, because with this diagnosis, you can't see signs like they're moving less, because they're already not moving. So it took us having bradycardias during an illness that sent us to the ER to tell us that the glucose reading was 50. We had no idea otherwise. As far as the BiPAP though, we knew that we needed it because he started having desaturations. At first it was like 3 a night, then the next week it was 6 a night, and the next week it was like 10, and then it got to 50 to 100 a night, down to 90, 91. And he goes to Johns Hopkins and they told me, oh, 90, 91, that's nothing to be concerned about, he's still fine. And I just knew that something was wrong because he was at 98 to 100. And when we first had the BiPAP, he hated it, he absolutely hated it. But I'm so glad that we actually pushed for him to get used to it, because that was in May that he got it. In November, he started crashing in the ER and they had no idea, they were kind of frantic, giving him straight oxygen. And I basically yelled at the resident, you can't just give him oxygen. They were leaving it on it because he was going down to 70 and staying there. And I'm like, you have to go get a ventilator, because I had left it at home that trip. Now I always take ours to the ER. Because quite frankly, they're not always treating him right in the ER because they don't know him. I have to educate them every time. And with that hospital stay, as soon as they got the ventilator and BiPAP setting, he didn't really need oxygen an hour later. He just needed BiPAP for 3 days straight. And after that hospital stay, he loves his BiPAP. As soon as I put it on at night, he falls asleep instantly. It's like a pacifier to him. So what was suggested to us as far as the BiPAP in particular was put it on during the day, watch shows with him, cuddle with him, don't even do it at night, and then build it up. And eventually he was used to it before that hospital stay, but after that hospital stay, he likes it now. And I've read posts from some of you on Facebook that have kind of said the same thing, when the child is cognitively able to speak, they say that they like the cough assist and they like BiPAP because it helps them, and they realize that. And it's hard with the babies because, they're screaming during it and they don't understand that we're trying to help them. But I saw firsthand, Micah's been in the ICU twice this year, and he needed BiPAP. That's what he needed more than anything else. So.
Thank you.
I was just gonna, again, Owen's 15, 16 next month, and it's definitely a balance because our kids' lives could be nothing but therapy, doctor's visits, needle sticks, and not being a kid. So for me, when he started, he's a very smart kid, and he would get to the point with the standard during the school day, he would fret about the standard. It would not be paying attention to his schoolwork. So we dropped the standard. He's a straight A student, so the standard's not gonna get him into college, and I keep telling him he's going to Harvard and he argues with me, but, that's the way he's being pushed because he has a very big brain and he can make a difference, so we chose to just nix the standard. During the school day, he has never been pulled out for therapy, ever. So he goes, if he has to go to the restroom, he already has to have extra breaks. But other than that, he is a kid while he is in that classroom, and we do everything outside of that. I didn't want the stigma. He's got enough of a stigma, right? I didn't want something else. Well, why is he getting pulled out of the classroom? What's happening with Owen now? So we made a decision that during the school day, he is just a child, in school. So it is a balance. You'll find your own balance. I think if it's, something that's dire and detrimental, if the standard, would have made him walk, by all means, the kid would have been in the standard every single day. But it just was not worth it for him academically, in my opinion. So, you just will strike your own balance, I guess is my point.
Tiffany, I don't want to put you on the spot, do you want to comment?
Okay, so a LAMA2 patient point of view, I know most doctors and researchers are not going to do this, but I have a BiPAP from age 8. I'm 29 now, and I hated the thing. And I used to it, I was totally non-compliant for doing for the first 5 or 6 years. And my mom would do every test she could do to get me to bed at night. We had this appearance that I worried that if I had a friend sleepover, I didn't have to wear it. So there was one weekend, it was a holiday weekend, and a friend sleepover for 3 nights in a row. So I didn't wear it on the day before. I woke up with full-blown pneumonia. So it's gonna take, it may take that one big stare for your child to realize that it does help. And unfortunately, it took me that long. I did then become more compliant with it at night. It also helped that not every machine is going to work well for the patient. I didn't like the machine I had at the time. To get me back out of the hospital, pulmonologist switched machines. And as a ramp function, so when I first put it on, it sits out at like very low pressure. I would kind of fall asleep. And it slowly increases, so not lots of air in the face. It may just be the mask sometimes people. So there's a lot of different medical standpoint tactics you can try if home tricks aren't working.
Thank you.
You could wear it too. You could put it on and wear it for a while. We had to do that with Owen when we first started.
So I'm a certified child life specialist at Levine's in Charlotte, and I've heard a couple of people in their presentations mention child life. Some hospitals have it and some don't. I'm fortunate enough to have that hat as well as know a lot of the physicians, so that's helped me. But as far as advocacy for other families, if you have a child life team, they are phenomenal educators and supporters. They know development. Sometimes the psychosocial side of it far better than some of the physicians and nurses that we work with. So I've had to take that hat off at the hospital and let some of my coworkers do that for my daughter. We also have a phenomenal pulmonologist that just got added to the team, Dr. Rosemary Magala, who was at NIH for a while, who introduced BiPAP. But I feel like we found when Elliot was super duper sick was when we had the best acceptance of equipment like BiPAP. It took severe RSV for her to finally realize it was great. So I feel like sometimes when you're not having the best result, and that sounds really awful because preventative is better, when he's sick, he will learn that it works, even at a young age. Elliot was 2. Also, as far as the stander, we hate the stander. We have a Bantam sit-to stander. I mean, that's as good as it's gonna get. We roam and chair for about 20 minutes and then we get angry and we get out of it. So we looked into the market and said, what else is there that can give her good gravity on her bones? Because that's really all we're looking for is bone density. We're not looking to stretch to walk. We're happy in our power chair and that's where we're gonna be. We're fine with that. So we found a company called Enlighten, which makes harnesses. They're 10 by 10 portable. And she gets in her harness and bounces around at 10 by 10 in her playroom. So, you know, that's how we get our bone density, because we hate the stander and it collects dust. So, you know, there are some companies that you'll find, Enlighten, if you're looking it up. It's up to 60 pounds for their 10 by 10. Costs about $4,000, is not DME, so that's that. It's a really amazing Christmas gift for the richest person in your family. So that gave her autonomy at the age before a power chair, and it gives her a stretch, and it is a workout, and she's ready for a nap afterwards. So.
I think we were kind of running along with Annie.
I'll make this really quick. Just from a parent standpoint, Ashley is 15, and I have 2 other unaffected children as well who are younger. I think that there is a tremendous amount of guilt on a parent, whether you want to admit it or not. There just is. You always feel like you're not doing enough, and when you feel like you're doing enough therapy, then there's not enough fun time. So my advice to any of you that have young children especially, you will learn so much over the years and you will completely change your views about life. When Ashley was young and a baby, there was so much guilt because we had all these therapies, we had to do belly tone, we had to put on the AFOs, we had to get the standard. It could consume you. Don't let it consume you. I think the biggest thing is you have to be a mom and you have to be a human and you have to be a wife. But don't let it consume you because it can and it will. There are certain things that certainly you can't give up, BiPAP, the opposite. There's certain things that we have to continue, but there's also sometimes some fun risks that you have to take as a parent too. One of my favorite memories is when we went to Disney and we took Ashley on this huge water raft that we probably never should have taken her on. She had the time of her life. So I think it's just really important, just my parent advice. If I was sitting here and had a 2-year-old, I would look at, Trish and I who have 15-year-olds and say, how would you not put your child in a standard? You will learn. There are things that you have to balance and it's okay. So you have the Facebook group, you have all of us, and I think it's nice that we're very non-judgmental because it changes, but don't forget to balance your life. I think that's key.
I think that's perfect.